Okay, so the topic for today's lecture is the third part of the neurovascular anatomy. And so I hope that people who are attending this class have attended the first and the second part. So today we'll be covering the topic of the cerebral arteries, and this is actually the most important part of neurovascular anatomy. So we'll cover it in a little bit of detail. It's not very difficult. A lot of it is things that you should already know, most likely. So we'll just go into a little bit of detail uh, at a much higher level. So first, let's discuss about the anterior cerebral artery. So the anterior cerebral artery, as it has been described, originates obviously from the ICA bifurcation, and it has been described to have multiple different divisions by different authors. So the most common described division is for the ACA into 5 different segments. The first 2 segments, that is A1 and A2, are considered the proximal ACA, and the rest A3, A4, and A5 are considered the distal ACA. So how the ACA develops is basically when during the fetal stage, the primitive ICA gives rise to a structure called the primitive olfactory artery, and the ACA arises as a branch from the primitive olfactory artery. Following which both the ACAs will join together in the midline and they will form a plexiform anastomosis. And this plexiform anastomosis is what gives rise to the anterior communicating artery later on. From this anterior communicating artery, which is formed, the medial artery of the corpus, the median artery of the corpus callosum arises, and this is supposed to regress later as the distal ACA gets formed. As we know, the ACA arises from the ICA bifurcation at the level of the anterior perforated substance. The A1 and the A2 segments of the proximal ACA are divided as follows. From the ACA origin up till the anterior communicating artery is the A1 segment, and from the anterior communicating artery till the geno of the corpus callosum is the A2 segment. Okay, the ACOM itself can be a little bit of a complicated structure. The normal ACA ACOM complex is where the ACOM is going to connect A1 ACAs which are of equal size. So that is a normal anatomy. There's a ACOM which is connecting A1 ACAs of equal size on both sides. And the usual diameter of the ACOM is supposed to be 1 millimeter less than that of the A1 ACAs. The more unequal the A1 ACAs are, the larger the diameter of the ACOM, because now the ACOM has to actually function to supply blood from one side to the other side. Now, if both A1 ACAs are of equal size, there's a very good chance there's probably no blood flow happening through the ACOM. The larger one side of one side AC is, the larger the ACOM will be to supply blood to the opposite side. The ACOM is not always going to be oriented in a transverse plane. Sometimes it might be twisted and tilted. So it can either be oblique or it might even be completely antero-posterior if one of the A2 ACAs is lying anterior to the other A2 ACA. There can also be multiple ACOM arteries. One ACOM is present in 60%, while in 30% there are actually 2 ACOMs, and in 10% you can have 3 ACOMs. The A2s, this is the A1. The A1s course over the optic chiasm in 70%, and they course over the optic nerves in 30% of the brains. And the ACA ACOM junction will lie either within the interhemispheric fissure or just below it. The only branches which arise from the A1 are perforating branches. There are no cortical branches arising from the A1. There are about 1 to 12 medial lenticulostriate arteries which arise from the A1, and they run directly up into the anterior perforated substance. There are also small perforators which run down from the A1 ACA, and they supply the optic nerve and the optic chiasm. There are perforators which arise more distally from the ACOM and the A2, and they will supply more distal structures like the corpus callosum, the septum pellucidum, and the columns of the fornix. So that is in relation to where these vessels are situated. The other branches which arise from the ACA, which are important, are the recurrent artery of Humna. This is one of the most important branches of ACA, of the proximal ACA. 78% of the recurrent arteries of Humna arise from A2 itself. 14% of them arise from A1, and 8% arise directly from the A1-A2 junction, where the ACOM is. The important thing to remember when you're clipping ACOM aneurysms are that 52%, almost 50% of recurrent arteries of Humna will arise within 2 millimeters of ACOM. 80% will rise within 3 millimeters of ACOM, and 95% within 4 millimeters of the ACOM artery. There are also cortical branches which arise from the ACA. As we discussed, there are no cortical branches arising from the A1 ACA. The A2 does have cortical branches, and the first group of these is the orbital branches, which is going to supply the orbital surface of the frontal lobe. The most prominent one being the orbitofrontal artery. And the second group is the frontal branches, which supply the medial frontal surface. And the most prominent of these is the frontopolar artery. Coming to the vascular territories of the ACA, the vascular territories, basically, as we saw, the ACA gives rise to perforators as well as cortical branches. It is important to know as to what structures, what are the deep cerebral structures which is being supplied by the different cerebral arteries. So when it comes to the proximal ACA, the perforators arising from the proximal ACA are going to supply, particularly you have to remember, is the head of the caudate. The other structures are the medial part of the putamen and the globus pallidus, and the inferior and medial part of the internal capsule anterior limb. It also, as we know, as it's close enough to these structures, it will also supply the corpus callosum rostrum and part of the anterior commissure. The other important artery rising from the ACA is the recurrent artery of Huebner, and the vessels being supplied by this will supply the anterior part of the caudate nucleus, the putamen, and the globus pallidus, and the anterior limb of the internal capsule. Similar to the structure being supplied by the ACA itself, but also it supplies the uncinate fasciculus. So when you occlude the recurrent artery of Huebner, which can happen when you're clipping ACOM aneurysms, you will get a predominant hemiparesis with facial and brachial predominance. And that happens because you are affecting the part of the internal capsule near the geno. Also, because you can affect the uncinate fasciculus, you can have aphasia if this involves a dominant hemisphere. So the cortical branches, on the other hand, have the following vascular territory. So this shading can help you decide as to what is the minimum amount of vascular territory being supplied by that structure. And this shading will help you decide what is the maximum amount. So as we can see, the minimum amount of ACA supply, okay, is on the medial surface is at least the anterior 1/3, and on the convexity, at least this structure has to be supplied by the ACA. But depending on the amount of collaterals and its anastomosis with the MCA, it can supply a significant amount of the convexity as well posteriorly on the medial surface as well. Okay, so coming to how the ACA looks on angiography. So as we know, the ICA bifurcation on an AP view is going to end up forming this T-shaped structure, which divides into an MCA and the ACA. And the ACA is the smaller branch. The MCA is usually twice the size of the ACA. The A2 segments, that is again the A1 segments. The A1 segments can be variable, so they can be horizontal, or they can even ascend up like this, or they may even descend down. Okay, and the A1 segments on both sides can be quite asymmetric in size as well as position. After A1s, the A2s will always run in the midline. Okay, and they can, when they're running in the midline, they can have shallow, like only small undulations which go from side to side. But overall, the A2s should run in the midline. Okay, so here we can see that this is the A2, they're running in the midline, but there can be small curves extending to either side, but always the A2 should return back to the midline. The best view to identify the A1 AC is actually an oblique view, which is a 30 to 45 degree view. That is the most optimal view for visualizing an A1. So here we can see that in this oblique 30 degree view, the A1s on both sides are seen much more clearly. On a lateral view, the A1 obviously cannot be seen because it's a horizontal structure, but the A2 is much more clearly demarcated on a lateral view. So, and the A2 segment can also be quite variable. The A2 segment is the part which is going to be in front of the rostrum of the corpus callosum. The part which is bending around the gene of the corpus callosum would be A3. So this is the A2 segment. And this A2 segment can be quite variable. It can be anteriorly convex, or it might even be inferiorly concave. It can be acutely angled also. So what are some of the normal variants that we might see with proximal ACS? There can be a very common A1 hypoplasia. Okay, and that happens in 10 to 25% of normal individuals. And as we know, the smaller one side A1 is, the larger an ACOM will be. So here, if the contralateral A1 is hypoplastic, we know that this A1, the dominant one, is supplying both A2s through the ACOM. The important thing to remember is that in 85% of ACOM aneurysms, you're going to see A1 hypoplasia. And that makes a lot of sense. Because if The A1 is hypoplastic. There's a large flow through the ACOM, and because there's a large flow, it's most likely a little bit turbulent and most likely to give rise to aneurysms. So here, as we can see in DSA, this ICA is giving rise to an MCA, but absolutely no A1 ACA is seen here. Some of the anomalies which can happen with proximal ACAs include an anomalous origin of the ACA. This is very rare, and sometimes ACA might originate itself from the ICA itself at the level of the ophthalmic artery. If it happens like that, then it is going to be running below the optic nerve instead of above the optic nerve. Since it's an anomaly, it is also associated with other anomalies like A1 hypoplasia and aneurysms. There can also be an accessory ACA, and this, apart from a normal ACA, you get one more ACA which is arising from the ICA. And this, unlike the normal ACA, will also be running below the optic nerve, and it will supply the basal frontal lobe. You can also have a bihemispheric ACA. So in this, what happens is that the 1A2 is just hypoplastic. It is not going to supply any structure. So both sides of the hemisphere are being supplied by 1A2 itself. Okay, so here that is what is known as a bihemispheric ACA, and that is seen as 2 to 7% of individuals, and it is to be differentiated from another anomaly that is known as an azygous ACA, in which there's only one A2. Okay, so there will be no contralateral A2 found in a azygous ACA. So as we can see here clearly, there is one hypoplastic contralateral A2. So this structure is actually a bihemispheric ACA and not an azygous ACA. On the other hand, this anomaly is an azygous ACA, and this happens because the median artery of the corpus callosum, as we discussed, is now persistent instead of regressing. So this happens in 0.2 to 4% of individuals, and that's just a single unpaired ACA. There's absolutely no hypoplastic A2 ACA. So this can be associated with other anomalies like holoprosencephaly and neuronal migration disorders. It also does increase the risk of aneurysms. Other anomalies that may be present are duplicated ACAs. There could be two normal A2 segments, plus there might be a embryonic median artery of corpus callosum. So you actually get 3 ACAs. This is seen in 2 to 13% of individuals. You can also get a persistent primitive olfactory artery, and this, as we know, that the primitive olfactory artery is what gives rise to the ACA. So if it persists, it is a very anomalous vessel, and it is associated with a long ACOM, an absent recurrent arteriofibular, and there's a very high chance of forming aneurysms with a persistent primitive olfactory artery. Coming to the distal ACAs, that is the A3, A4, and A5 segments. As I mentioned, the part which is curving around the genome of the corpus callosum is A3, and the parts distal to it are A4 and A5, and A4 and A5 are separated by the plane of the coronal suture. The distal ACA runs under the inferior margin of the fox, but the branches of the distal ACA will always be running adjacent to the fox. They will not be under the fox itself. Okay, so what are the branches which arise from the distal ACA? As we've seen, the A2 will be running in front of the rostrum of the corpus callosum, following which the A3 will wind around the genu of the corpus callosum. So it is at the junction of the rostrum and the genu usually where the A2 bifurcates, and it bifurcates into a pericallosal and a callosomarginal artery. This callosomarginal artery may actually be absent in 20% of patients, and 20% of individuals, and these pericallosal and callosomarginal arteries are actually inversely proportional to each other. So one is larger in size, the other will be smaller in size. Okay, so another important thing to remember is that this anterior part of the ACA, this part is at some distance from the fox, because the fox is not tightly opposed to the corpus callosum anteriorly. It is opposed to the corpus callosum posteriorly though. So here anteriorly and posteriorly, the pericallosal artery is more or less free under the fox. But the callosomarginal artery is free only under the anterior part of the fox and not in the rest of the fox. So that is why when there is midline shifts, only the pericallosal artery will be able to shift to one side, but the callosomarginal artery will not shift. So you can identify these midline shifts on DSA using these arteries as well. Now, what are the branches which arise from the distal ACA? The important branches are the parietal branches, particularly. So the arteries which arise in the distal ACA will be called the parietal branches. Okay, and they will supply the medial surface of the hemisphere and part of the adjacent convexity as well. So the vascular territory, more or less, of the ACA is that it supplies the anterior 2/3 of the medial brain surface and also a small strip of cortex extending over the convexity, which will overlap with the MCA blood supply. So what is the normal angiographic anatomy of the distal ACA? As we saw, distal ACA will be just seen as a simple midline structure on AP views, right? So on lateral views is where you can make out the anatomy better. So in the lateral view, you can easily see the callosal-marginal artery and the pericallosal artery. So the artery which is running above, that is the callosal-marginal artery. And the artery which is running below, that is the pericallosal artery. So this pericallosal artery will run right over the corpus callosum. And the callosal-marginal artery will run in the cingulate sulcus over and above the cingulate gyrus. Here, the distal ACA branches, which are rising distally, they will be overlapped by the MCA branches. So here you will not be able to identify the distal ACA branches. In the AP view, you cannot distinguish between the pericallosal and callosal marginal arteries. A little bit of a difference is that the callosal marginal arteries will be a little bit more serpentine, while the pericallosal arteries will be straighter, but not really the best way to differentiate on an AP view. So in the distal ACA, it's very unlikely you'll get any anomalies of the distal ACA. A variant can exist where you have a communication between the distal ACAs, and that is known as a superior anterior communicating artery. And it can lead to an increased risk of formation of aneurysms in the distal ACA. Now coming to the middle cerebral artery. The middle cerebral artery, as we discussed, also arises at the ICA bifurcation, and when it arises, the size of the MCA is going to be twice the size of the ACA, so it's almost 2.5 to 5 millimeter in size. There are 4 segments of the MCA. There is an M1 segment after it arises, okay, and the part which runs horizontally up till the point at where it bends. That is known as a horizontal or the sphenoidal segment because it runs along the sphenoidal ridge. The M2 segment is the part after the genu, or the part where the MCA bends, and that is the insular segment running on the surface of the insula. Then you have an M3 segment which runs along the opercular surfaces of the frontal and the temporal opercular, and the M4 segments are going to be supplying the cortical surfaces. Okay, so the development of the proximal MCA is very intimately linked to the Sylvian fissure development. Sylvian fissure, how it develops is between 8 to 12 weeks, a shallow fossa will form the lateral cerebral surface, and it will just become deeper and deeper and deeper, and the frontal and parietal lobes superiorly and the temporal lobes inferiorly will fold over, and they will form opercula. So as we can see, this is the early part of the cerebral hemisphere development, but the Sylvian fissure is not yet formed. So after the MCA origin, it literally just comes up and supplies the cerebral hemisphere vertically. There's no Sylvian fissure here. As the Sylvian fissure gets formed, these vessels get buried deeper and deeper and deeper, and they form these M2 and M3 segments of the MCA. Okay, so coming to the normal anatomy of the proximal MCA. So it originates from the ICA bifurcation, and that's where the M1 segment lies. So that is from its origin up till the genu, the part where it bends up. Most commonly, the MCA will bifurcate before it reaches the genu itself. In 90% of cases, it usually bifurcates within about a centimeter of its origin. It most likely is going to be a bifurcation itself in 80% of cases. In about 10%, it can form 3 trunks also. And in about 10%, it can even form multiple trunks. Okay, and the M1 segment ends at the genu, and the genu usually happens at the Lyman insula. The M2 segment will then start at the genu, and it will follow the surface of the insula. So an M2 segment will bend at the genu, follow the surface of the insula. Okay, and then finally again it will bend at the opercular surface or the superior sulcus here to form the opercular segment or the M3 segment. The greatest branching of the MCA happens in this M2 segment itself. So after it forms the superior and the inferior trunk, it will form 6 to 8 major stem arteries, and those are all insular segments. So the proximal MCA, as we know, it will originate at the medial end of the Sylvian fissure, following which the M1 will run lateral to the optic chiasm and behind the olfactory trigone, and will run below the anterior perforated substance. And then, as we know, it will go on to reach the genu and bend there and form the M2 segment. So what are the important branches which will arise from the proximal MCA? So there are multiple perforators which arise from the proximal MCA, and the most important ones are the lenticulostriate arteries. And these arise from the M1 segment, not from the M2 segment, and they're usually 10 in number. There are both medial and lateral lenticulostriate arteries, and the larger number will be the lateral lenticulostriate. So the important thing to remember is most of these lenticulostriate perforators are going to be in the distal part of the MCA, the area where most likely you will be doing a temporary clipping. to control the proximal flow for MC aneurysms. The medial lenticular striate arteries will arise from the proximal M1. They are lesser in number than the lateral lenticular striate arteries. They will enter the anterior perforated substance and they will go through the lentiform nucleus and supply the lentiform, the choroid nucleus, and the internal capsule. But the lateral arteries, on the other hand, they will arise from the distal M1. They are more in number, and instead of going through the lentiform, they will ascend outside the lentiform nucleus, and then they will turn medially and supply the basal ganglia. The other arteries which arise from the M1 are also cortical branches. As we know that from A1 ACA, there were no cortical branches, but there are cortical branches arising from the M1 MCA. And the most important one is the anterior temporal artery. This arises from the M1 before the bifurcation itself, and it will directly pass anteriorly and inferiorly over the temporal tip. So it's an important artery identified during angiograms. It can lead to confusion where you think that the anterior temporal artery origin is the MCA bifurcation, but you should see where this artery is going. So we'll have a look in some of these angiograms. So this is a normal angiographic anatomy of the MCA. So in the AP view, the M1 segment will be usually very well visualized. And the M1 segment is usually horizontal. But if the patient is younger, the M1 segment might course superiorly. If the patient is older, it might course inferiorly. And that can actually figure out as to where the aneurysms of the MCA bifurcation may be directed. So if the MCA is coursing superiorly, the aneurysms will actually be directed inferiorly. If the M1 MCA is coursing inferiorly, the aneurysm will be directed superiorly over here. In the AP view, as you can see here, even these lenticular striate arteries are quite well seen. Okay, and how you can identify these is, you can see these arteries, they will first be coursing superior medially. After piercing the anterior perforated substance, then they will wrap around the basal ganglia. So they will then course superior laterally. So first superior medially and then superior laterally. So these are all the lenticular striate arteries. Okay, and this is the geno. This is the part where the M1 segment is finally turning up and becoming the M2 segment. This part, again, at the level of the superior sulcus, will bend again and form the M3s or the opercular segment. In the lateral view, on the other hand, you're not going to be able to see the M1 segment very easily. It will not be seen because it's a horizontal segment. The M2 branches, on the other hand, as we can see here, these are all the M2 branches and the M2 trunks, which are quite well seen in a lateral view. So these, as they're coursing along the insula, will be very well seen. And as we know, as they reach the superior sulcus, they're going to bend again and form the opercular segment. So this bend is very clearly seen between the M2 and the M3 segment. And this bend is actually angiographically quite important. So the most posterior artery and its bend, that is what is known as the angiographic Sylvian point. Okay, so that is the highest and the most medial point, as we can see even in this AP angiogram, the most medial and then the highest point where the last cortical MCA branch is going to turn. This is what is marking two structures, both the apex of the insula and the posterior limit of the Sylvian fissure. So on an AP view, these Sylvian points should actually correspond. They should be equally located next to each other. If they are separated widely, it might mean there's actually a mass effect on one side. There's also a structure known as the angiographic Sylvian triangle. So this is formed by three lines. First is this line which is tangent to the tops of the insular loops. As we saw, these are all M2, M3 insular loops, and the tops of these loops will join together to form this line. Then the next structure identifies the main trunk of the MC over here, and then the most anterior branch of this ascending frontal complex. These three structures will join together and form the Sylvian triangle. If there's any displacement of this Sylvian triangle, it also can indicate there's an intracranial mass. Okay, so coming to some of the variants and anomalies with proximal MCAs, some of the very common variants which can exist are an early division of this M1 segment. As we can see, the M1 arises and then just immediately more or less divides into the superior and inferior trunk. So if a bifurcation happens within 10 millimeters of the origin, that is known as an early division of M1 MCA. You can even have a very large anterior temporal artery. So here you can see this is the M1 and this is a superior and inferior trunk dividing. Okay, but this artery is actually the anterior temporal artery. Okay, so another thing where you can get confused is with an accessory MCA, and we'll discuss what that is. But you should not be confused between a bifurcation, as we can clearly see it as here, and an anterior temporal artery. Okay, so the some of the anomalies which can happen with proximal MCA include MCA duplication. Okay, so as you can see, this is the normal MCA over here. And before the ICA bifurcates into the ACA and the MCA, there's another vessel which is arising from the pre-bifurcation ICA following the course of the MCA. Okay, so that is known as a duplicated MCA. Okay, so it goes parallel and it goes inferior to the M1. It happens in 1 to 3% of brains and will supply mostly the temporal lobe. You can also have an accessory MCA that actually originates from the A1 ACA. So it courses parallel to the M1 as well, but it courses above the ACA. I'm sorry, above the MCA, not below. So this, on the other hand, is going to supply the frontal lobe. So this also happens in about 3%. The important thing is to differentiate this from a recurrent artery fumina, because both recurrent artery fumina and the accessory MCA will arise from the A1 or A2, and they will course backwards from that artery. Some other rare anomalies which can happen are a hypoplastic MCA that is very rare. Your MCA can penetrate and then join back together. Okay, or you can have a single MCA trunk which does not divide into a superior and inferior trunk. The M3 segment, that is the opercular part. So as we can see here, this is the part. So the M2 segment is the part running over the insula, and the part which bends at the superior sulcus, and then again bends at the cortical surface. That is the insular part. That is the M3 segment. So in the AP view, all the M3 segment of the different trunks will overlap with each other. But you can clearly make out where the M3 segment is as it's coursing away from the insula over here. On the lateral view also, you can slightly make out the M3 segment. You will see two curves. The one curve is where it is bending initially, and then another curve where it bends again. So that entire segment is the M3 segment. So what are the branches which arise from the distal ACA? There's multiple branches which arise from the distal ACA, and these are all named, and it is actually really important to know what these branches are, and they all supply different structures, and they're quite easy to remember, just the different lobes and what are the different areas that they're supplying. So there are three groups of branches arising from the MCA. There are anterior branches, there are intermediate branches, there are posterior branches. The anterior branches arise from the MCA, and they actually turn sharply upward or downward. These branches are turning up or they're turning down. Okay, so these include the orbitofrontal arteries supplying the inferior surface of the frontal lobe, and the prefrontal arteries supplying the frontal convexity. You have intermediate branches which, instead of turning sharply up or down, start gradually going posteriorly. So these are three branches: the precentral sulcus artery, that is pre-Rolandic, the Rolandic artery or the central sulcus artery going through the central sulcus, and the post-central sulcus artery or the anterior parietal artery. And then you have multiple posterior branches. So these actually follow the course of the Sylvian fissure. So this includes the posterior parietal artery, as we can see here. And that forms the anterior border of the supramarginal gyrus over here. Then you have the angular artery, which is the main terminal branch of the MCA. And this is one of the best branches to use for STA, MCA, anastomosis. You can also have the temporo-occipital artery over here, which is running in the superior temporal sulcus, the posterior temporal artery running in the inferior temporal sulcus, and the medial temporal artery. The MC also, as we know, gives rise to the perforating branches, as we know, lenticular striates. And apart from the basal structures and the basal ganglia being supplied by these arteries, there are MCA perforators which also supply the optic radiations and the arcuate fasciculus. So these are cortical branches and supply of the MCA. As we can see, most of the the convexity hemisphere is supplied by the MCA itself. On the inferior surface, predominantly the frontal lobe and the temporal pole, and on the medial surface, it is mostly the temporal lobe being supplied by the MCA. It is also important to remember that the MCA superior trunk and the MCA inferior trunk supply different structures. So there can be sometimes blocks which happen in one particular trunk. So the other trunk will be spared, and supply of those structures will also be spared. So superior trunk will usually supply structures from the orbitofrontal area all the way up to the posterior parietal area. But it can extend its supply and even get into the temporo-occipital area. The inferior trunk, on the other hand, supplies all this inferior structure. So it usually supplies from the angular area up till the temporopolar area, but it can extend its supply and supply even up till the pre-central area over here. Okay, so as we know, we saw multiple perforators, and it can be a little bit confusing as to what the different perforators are supplying. So here is a table which elucidates what are the different structures being supplied by different perforators. First of all, it's important to realize that where do these perforators arise from? Okay, so the perforators arise from most of them arise from the circle of Wells itself. So you have perforators arising from the C4 ICA, from the anterior choroidal artery, from the MCA, that is the lenticular striate arteries, from the A1 ACA, and from the recurrent artery of Huebner. So these are the major perforators which are arising from the anterior part of the circle of Willis. These are different structures of supply. So all of these, there's a significant amount of overlap which happens with these different perforators. The important thing to remember is that when it comes to the supply of the internal capsule, the superior part of the internal capsule is predominantly supplied by the branches of the middle cerebral artery, that is the lenticular striate arteries. Okay, the anterior limb inferior part is supplied by the recurrent branch of anterior cerebral or the recurrent artery of Huebner. The genu is supplied by branches from the ICA and the posterior communicating arteries. And the rest of the internal capsule is supplied by the anterior choroidal artery. So hopefully this diagram helps to remember the supply of the internal capsule. This is another diagram which helps you remember that what are the perforators arising from the ACA and MCA and what are the different structures of supply. So as we can see, the ACA perforators supply most of the anterior structures. They supply the caudate head and the anterior part of the basal ganglia, while the rest of the basal ganglia are predominantly supplied by the MCA perforators. Okay, now coming to the posterior cerebral artery. The posterior cerebral artery, as we know, does not arise from the ICA, it arises from the basal artery and at its bifurcation. Okay, and there are 4 segments also of the posterior cerebral artery. The segments are P1, P2, P3, and P4. And the P1 segment is the pre-communicating segment that is from the origin up till the point of posterior communicating artery. The P2 segment is a segment which is running in the ambient cistern. The P3 segment is the part running in the quadrigeminal cistern. And P4 segment will be the part running in the calcarine fissure. Okay, so how does the PCA arise and what is its normal development? Basically, the PCA actually arises from the PCOM. The primitive vessels arise from PCOM and supply the midbrain and the thalamus and choroid plexus will all fuse together and they will form the PCA. So in the fetus, the PCA arises from the PCOM and is supplied by the ICA. As the PCOM regresses, the PCOM will regress as the vertebrobasilar system develops and annexes this PCA supply. Coming to the gross anatomy of proximal PCA, it, as we know, originates from the basilar bifurcation, and it has the proximal PCA is divided into the P1 and the P2 segment. The P1 originates at the basilar bifurcation and runs up till its junction with the PCOM, and it actually gives rise to a number of perforators, which will predominantly supply the nearby structure, that is the brainstem and the thalamus. The P2 segment, on the other hand, extends from the PCOM junction with PC up till the posterior aspect of midbrain throughout the ambient cistern. It actually will course in this ambient cistern along with the optic tract and the basal vein of Rosenthal. Here it will give rise to multiple perforating arteries, but apart from perforators, it will also give rise to ventricular branches and cortical branches. So one of the most common relationships is that here, as we can see, this is the third nerve. The PCA always is going to run above the third nerve. It also runs above the trochlear nerve. It courses medial to the tentorial incisura, and then it goes above the tentorium because it supplies the posterior cerebral surface. It will then terminate below the occipital and posterior temporal lobes by dividing into its terminal branches. So what are the branches which arise from the proximal PCA? There are 3 different types of branches. First is the perforators which arise from the proximal PCA. As we saw, the P1 PCA gives rise to only perforating arteries. So the posterior thalamo-perforating arteries arise from the posterior superior aspect of P1, posterior aspect and the superior aspect. And then from there, it will pass into the posterior perforated substance, and there are 1 to 6 in numbers. You also get thalamo-geniculate arteries arising from the P2 or the P3 segment. In 80% of cases, they arise from P2, and in 20% in P3 segment. There are also peduncular perforating arteries which arise from P2 and directly perforate and supply the cerebral peduncles. Apart from these perforators, the proximal PC also gives rise to ventricular and choroid plexus branches. And these are important. You have both the medial posterior choroidal artery and the lateral posterior choroidal arteries. It is important to remember that most likely both these arteries are arising from the P2 itself. The medial posterior choroidal usually arises as a single vessel, most likely arises from P2, but can also arise from the P1 or the parieto-occipital artery. It will wrap itself around the brainstem, go posteriorly, run above the pineal gland, and enter the roof of the third ventricle. The lateral posterior choroidal arteries, on the other hand, they are going to be multiple arteries arising directly from the P2, and therefrom they will run laterally and they will go through the choroidal fissure and enter the choroid plexus of the temporal horn. So here, the medial posterior choroidal arteries enter the third ventricle, and from there they go to the foramen of Monro, and then they enter the choroid plexus of the lateral ventricle. On the other hand, the lateral posterior choroidal arteries will enter into the temporal horn, and from there they will run behind the pulvinar and then go near the foramen of Monro to anastomose with the medial posterior choroidal arteries. The lateral posterior choroidal artery is also obviously anastomose with the anterior choroidal artery, which is directly supplying the temporal horn choroid plexus. There are also branches arising from the proximal PCA which supply the cerebrum. So these are the anterior and the posterior temporal artery. They are both arise from the P2 segment, and they usually anastomose with branches of the MCA. An important aspect of the posterior temporal artery is that in 20% of cases, it can supply the macular area of the visual cortex also. So this is the normal angiographic appearance of the proximal PCA. In a lateral view, the P1 segments will not be visualized. As we know, they are horizontal segments. So P2 segments, on the other hand, can be very well seen, and they usually have an inferiorly convex configuration. The point at which they start turning up, that is the junction of P2 and P3. In the lateral view, we can also very clearly see perforators and choroidal arteries. So these are some of the perforators directly arising from the basilar bifurcation and PCA, usually the thalamoperforating arteries. You can also see both the medial posterior choroidal artery and the lateral posterior choroidal artery. The medial posterior choroidal artery, because of all its multiple bends, one bend to enter the third ventricle roof and then another bend to wrap around the foramen of Monro, ends up making it look like a 3 shape. There's also, if you wait for a delayed capillary phase, you can actually make out the choroid plexus being supplied by the posterior choroidal arteries. In the AP view, on the other hand, now finally you can make out the P1 segment. So here we can see the P1 segments quite clearly, and below them the SCA is also seen. And this blush represents the thalamoperforating arteries. You can also clearly make out the P2 segments as well. And then following which, as we know, the point at which it turns up, but also turns medially. That is the P2-P3 junction. Following which the P3s will course medially and then finally turn up to enter the calcarine fissure and form the P4 segments over here. The branches which are running laterally, on the other hand, from the posterior cerebral arteries, these are the lateral posterior choroidal arteries. So if we wait for a delayed blush, we can see this curved structure on both sides. This is the choroid plexus being supplied by the lateral posterior choroidal arteries. Okay, so what are some of the normal variants associated with these arteries? There can be a side-to-side asymmetry where one of the P1 is larger and the other P1 is smaller. Okay, and also one of the most common and important variants which can exist, that is the fetal PCA. This fetal PCA has about a 20% incidence. And here, the ipsilateral P1 will be smaller than the PCOM because the PCA is being supplied entirely by the IC through the PCOM. So as we can see here, this PCOM is quite large and it is supplying the PCA predominantly. You can also have some anomalies with the relation to the proximal PCA. This is the persistent carotid basilar anastomosis, as we have discussed previously. As we can see, this artery is arising from the cavernous segment of the ICA, and it is anastomosing with the basilar artery over here, and it is what is supplying the predominant supply to the PCA. Okay, so when it comes to the distal PCA, there is the P3 and the P4 segments. The P3 segment is a very short segment. As we know, it turns medially and up from the P2 segments. And it extends from the quadrigeminal plate up to the calcarine fissure. And the P3 segments will usually approach each other on an AP view. The P4 segments, on the other hand, represent a termination of the PCA within the calcarine fissure. And this PCA bifurcation usually happens between the P3 and P4 segment. And this bifurcation should obviously lie above the tentorial incisura, but it lies below the lateral geniculate body. The PCA will divide into two trunks before it reaches the calcarine fissure, and these trunks will give rise to medial and lateral branches. So the medial branches which arise from the distal PCA include the parieto-occipital artery, the calcarine artery, and the splenial artery. These are very important arteries. The parieto-occipital artery runs in the parieto-occipital sulcus. The calcarine artery is the main supply of the visual cortex. And the splenial arteries will arise from the PCA itself or from the parieto-occipital artery, and they will wrap around the corpus callosum and form the posterior pericallosal artery. So they will then anastomose with the pericallosal branches of ACA. So these anastomoses between the ACA and PCA at the pericallosal level are quite important in diseases like Moyamoya disease. There are also multiple lateral branches which arise from the PCA, the anterior inferior temporal artery, the middle inferior temporal artery, and the posterior inferior temporal arteries. Also, what are the vascular territory of the PCA itself? So as the perforators, as we saw rising from the PCA, are mostly going to be supplying the thalamus and the brainstem. So there are posterior thalamoperforating arteries which supply the thalamus, hypothalamus, the posterior part of the internal capsule, and the midbrain. Okay, so these structures. There are also thalamo-geniculate arteries that supply even more posterior structures, predominantly the pulvinar and geniculate bodies and the subthalamus. There are also peduncular perforating arteries supplying the midbrain. As we know, there's also choroidal and ventricular branches, predominantly of medial and lateral posterior choroidal arteries, which supply the choroid plexus of third and lateral ventricle respectively. There are also cortical branches, and we can see the supply over here. The predominant supply is the medial hemisphere surface, the posterior part, which is not being supplied by the ACA. And the other predominant structure being supplied is a temporal lobe. So a majority of temporal lobe can be supplied by the PCA itself. The occipital lobe more or less is supplied by the PCA. And the medial surface of the hemisphere can also be supplied by the PCA up till almost the anterior 1/3. This is the normal angiographic appearance of the distal PCA. So here we can see the distal branches of PCA, the calcarine arteries and the parieto-occipital arteries, which are running in the calcarine fissures. Okay, so that is all for today's class. I hope all of you have understood at least a few basic concepts about the different cerebral arteries. So let's revise some of these topics with a few practice questions, and you're all welcome to put down the answers in the chat box. So the first question is, the anterior thalamoperforating arteries will arise from which of these vessels? The anterior choroidal artery, the P1 PCA, the P2 PCA, or the posterior communicating artery? So for those who want to answer, please put down the message in the chat box. Okay, so one of the answers is posterior communicating artery. So it is important to remember, as we had discussed in the previous video, there are structures called anterior thalamoperforating arteries and the structures called posterior thalamoperforating arteries. So these thalamoperforators arising from the basilar bifurcation and the PCA are known as the posterior thalamoperforators. The anterior thalamoperforators will arise from the posterior communicating artery over here. Okay, so the next question, an accessory ACA has what relation to the optic nerve? Is it superior to the optic nerve, inferior to the optic nerve, lateral to the optic nerve, or medial to the optic nerve? Okay, this is a slightly difficult question. So an accessory ACA is arising from the ICA itself. So it actually arises from the pre-bifurcation ICA, and then it runs below the optic nerve. The normal ACA is going to run above the optic nerve. So it's important to remember that an accessory ACA will, on the other hand, run inferior to the optic nerve. Okay, so this one, if we have paid attention to the class, should be quite easy. Identify this anomaly, please. Is it an azygous ACA? Is it a hypoplastic A1? Is it a normal configuration? Is it a bihemispheric ACA? So this is probably the easiest question here. This A2 is hypoplastic, and this A2 is supplying both hemispheres. So this is a bihemispheric ACA. Okay, identify this vessel. Okay, so this I have not actually mentioned this artery during the lecture, but if you had paid attention to some of the pictures, this artery has been labeled. So this is a thalamoperforating artery, yes, but this is the single thalamoperforating artery, which is arising from one side PCA and supplying both the thalami. Okay, so this structure is called the artery of Percheron. Okay, so which of these following vessels will supply the superior limb of the internal capsule? The recurrent artery of Humner, lenticular-striate arteries, anterior choroidal artery, and posterior communicating artery. Okay, so that is correct. The superior part of the internal capsule is supplied by the lenticular-striate artery. So if you remember this diagram, it's one of the most useful ways to remember what is the blood supply of the internal capsule. Okay, so that is all for today's class. I hope you all learned something, and thank you for attending. If you have any doubts, I'll leave a feedback form for which you can submit any doubts if you have them.